Welcome everybody to the inaugural race Grand Round. Nundiandu, welcome to the Riverland Mallee Coorong, the land of the Northern Jerry, the Meru, the Narkat, amongst other Aboriginal peoples. And it's very appropriate that we acknowledge that there's been health education and healthcare on our country for thousands of years. Our Grand Rounds are our way as Riverland Mallee Coorong of engaging with the best in the world, of having our minds and eyes open to ideas and thoughts from thought leaders, and being able to engage in those so that our communities can benefit. And who better to lead off those Grand Rounds than someone who is an international thought leader? Our current National Rural Health Commissioner, Professor Ruth Stewart, a rural generalist who I first knew from her time in Camperdown, and have followed her across Australia to her current location in Roma, where she is continuing her work promoting the reforms that are needed in Australia's health system to be able to provide the care that rural Australia deserves. I think we will really enjoy the time that we spend with you, Ruth, and thank you very much for making the time available to be with us. We'll listen to you, and then a time for questions after that, and everybody can get back to their clinical work and other work at 1:30. So welcome, Nundiandu.
Thank you very much, Paul, and thank you. I feel very honoured to speak for the inaugural Grand Round for race. It's a very exciting initiative, and it's very exciting to be here in the first Grand Round. So I've prepared a talk, and I will now share my presentation. And just, can you see that now?
Yep.
Great, okay. So, thank you everyone. I want to begin by acknowledging the Mandindangi Nation, who are the traditional custodians of the land where I stand today. I pay my respects to the Mandindangi elders past, present and emerging. I also pay respect to the elders of the traditional custodian nations of the lands on which you sit or stand or walk, whatever. I extend my respect to Aboriginal and Torres Strait Islander people who are here with us today, and may your achievements in your field be celebrated and provide continued inspiration for young health professionals and medical students. Thank you for your efforts. So, what is the role of the National Rural Health Commissioner? Well, it's set by legislation. It's a statutory position. If there were legalists amongst you, I might cite the chapter and verse of the Health Insurance Act, but I won't. The Statement of Expectations is a letter that comes to me from the Minister for Regional Health and covers 2 years. The former Minister for Regional Health, Mark Coulton, gave me my letter and statement of expectations, and I have responded to that with a statement of intent, which outlines the approach I intend to take to achieve the goals that have been set for me within the statement of expectations. Now, I'm not going to take you through that line by line. That'll be a bit tedious, but let's just have a look at the headlines. So I aim to achieve the goals and priorities, to engage with rural, regional and remote stakeholders, and to maintain a strong policy focus on the health needs of rural and remote communities. The what's my work and how? What does it look like? So I've got responsibility to support urgent and emerging issues. Now it's obvious that the major one in this, these days is COVID-19 and the impact it's having in rural and remote communities. I chair the Rural General Practice Respiratory Centre Leaders Network, which was established by Professor Paul Worley, who you know well, who was my predecessor in this role. Thank you, Paul, for all your work. And I also participate in and co-chair a number of other committees, always bringing the issues that are important in rural and remote Australia to the forefront. For example, the most recent issue was the difficulty that rural communities were having accessing rapid antigen tests, and I advocated strongly for the provision of those into rural and remote communities, particularly into the GPRCs. I'm to support innovative models of care, such as the grant opportunity that was established by my office working with the Department of Health. We refer to this as PRIM, the Primary, Rural and Remote Innovative Multidisciplinary Models of Care grant opportunity, which provides money to develop a concept for implementation. We have already given out 2 of those grants. 2 other applicants have been selected and will be announced very soon, and there will be one further round under that program. There's also the Innovative Models of Care grant opportunity, which sits outside of PRIM. Then rural workforce training and primary care reform. I often feel that this is the central piece of my work. You'll recognise that as a push for rural generalism. So it's not just rural generalism in medicine, although that is an important part of my work. It's also rural generalism in allied health and nursing. And stakeholder engagement. My work is only as good as the validity that it has. So if I am deeply engaged with the key stakeholders in rural and remote health, I am more likely to represent their issues in the discussions that I have in Canberra and around the nation. So my office the staff in my office like to call this, like to focus on the fact that we represent, we engage, we actively pursue, we challenge, and we highlight. They call this, we reach into communities and enable rural communities to reach and influence Australian health policy. And the Office of the National Rural Health Commissioner is central to that action of reaching into Australian health policy. So what are the priorities of my office? Yes, as I've mentioned, the rural generalist pathways in allied health, medicine and nursing. I've come to realise during my term that general practice training, including the transition to college-led GP training, if that doesn't run smoothly, then rural generalist training will fall over. The Rural Health Multidisciplinary Training Program was evaluated, and I am working closely with the Department of Health on the implementation of the recommendations from that evaluation. It was a really good evaluation. The findings of it certainly resonated with the sector, and we just have to work out how to get those recommendations implemented. And then, as I've already mentioned, the primary care rural innovative multidisciplinary models of care grant opportunity. There are 2 more of these to be selected in the final round. Okay, so why are those priorities for the Australian government? Let's just revisit some of these things. Health status of Australians deteriorates with increasing remoteness. Life expectancy deteriorates with remoteness. Potentially preventable hospitalisations increase steeply with remoteness. And we are currently not providing rural people with the care they need. That's obvious from those statistics. And if that's the case, that needs to be fixed. Why do we think that rural generalism can address these issues? Well, a large part of our problem is the distribution of the rural health workforce is only one element of addressing the rural health outcomes. It's all very well, we tend to focus a lot on where doctors and nurses and allied health practitioners are. We also need to be focusing on what they do. We need the right doctor, allied health professional or nurse with the right skills in the right place at the right time. It's too late if they turn up the week after the major accident when there wasn't somebody with airway skills to protect and save a person's life. They need to be there at the time with those skills in the right place, right skills, right time. Okay, so why is rural generalism important for rural Australia? We know that we need to attract, retain and build a sustainable rural workforce. And if you are a rural generalist, you are trained and prepared to work across a broad scope of practice. So you're not going to be sitting idle, you'll be seeing what comes in the door. And you're trained to work in multidisciplinary teams so that you're not feeling professionally isolated because you understand that your colleagues are there within your multidisciplinary team. So the Rural Generalist broad scope of practice allows for the diversity of rural and remote communities. We don't set one set of skills. We say you need a broad scope, recognising that rural and remote communities in Australia are as diverse as a Kimberley mining site, a Aboriginal community on Cape York, a dairy farming community in southwest Victoria, and a fishing community in the south of Western Australia. So the rural generalists need comprehensive general practice and primary care skills, and those skills are needed both in medicine but also allied health and nursing. They need emergency care and components of other medical specialist care. Now, in that, I've just paraphrased what's known as the Colin Grove Agreement. Once again, hats off and very deep gratitude to Paul Worley for his leadership in establishing the Colin Grove Agreement, a definition of what rural generalism is in medicine. And yes, care in rural hospital and community settings. Now, I am tasked with establishing the National Rural Generalist Pathway, which was defined and described within a report from the National Rural Generalist Task Force to the inaugural Rural Health Commissioner in December 2018. So the National Rural Generalist Pathway describes a dedicated medical training pathway to attract, retain and support rural generalist doctors. It will require recognition of rural generalism as a specialised field within the specialty of general practice. That recognition needs to come from the Medical Board of Australia and the Australian Health Professional Regulation Authority, AHPRA. We need national consistency with the potential for local application of those standards, so that a rural generalist who is trained in South Australia can work just as well in North Queensland or in Tasmania. And we need to have a clear training pathway leading to jobs in rural communities, so that a medical student or nursing or allied health student can look ahead and see the job that they want to go to and see how they get there. At the moment, we don't have that yet. So what are the benefits of a national rural generalist pathway? It defines a role to aspire to. I love it when I meet a medical student who says, I want to be a rural generalist. It will give formal recognition of rural generalism within general practice, so that we will once and for all recognise that this is a distinct set of skills and type of practice. It'll give streamlined training, increased training support for those training for rural generalism, increased training and job opportunities, and we believe that it will lead to the retention of rural generalists in rural and remote communities. So I've mentioned the rural generalist pathway. What are the key activities? So it's raising the profile of rural generalism and its place in the health system. I feel like I spend my whole life talking about rural generalism, but I still come across people, mainly in the cities, who really don't know what rural generalism is and have no idea how it fits within the system. Just think it's a couple of rednecks out bush doing their own thing. We need to strengthen it. The National Rural Generalist Pathway will strengthen the training pipeline so that it will be very much easier to put your foot on the first step to training for rural generalism and just follow along that training without falling off because it's just too hard to get there. And by consulting with the rural health sector and other key stakeholders in rural generalism, we'll make this a really valid training pathway. So I've talked so far a lot about the rural generalism in medicine. Paul, during his time as National Rural Health Commissioner, also developed a report for the Minister for Regional Health on improving rural and remote allied health services. And importantly, it had 4 recommendations. So we are now progressing the remaining recommendations, which focus on access, quality and distribution of allied health professionals across Australia. So recommendation 1 is that there should be service and learning consortia established across the nation, so that there should be hubs where medical students and early career allied health professionals will learn and provide service in rural and remote communities. Recommendation 2 is that we should be investing in culturally safe and culturally responsive workforce, particularly in developing Aboriginal and Torres Strait Islander allied health professionals, but making sure that the rural generalist allied health professionals that we train understand how to provide culturally safe and culturally responsive services to the Aboriginal and Torres Strait Islander peoples with whom they interact. Recommendation 3 is that there should be a national allied health workforce data strategy developed. Now that sounds pretty obvious, but I can tell you we don't have one yet. So it's really hard to answer the question, how many occupational therapists are there? How many speech pathologists are there in different rural and remote areas? We just don't know. It's partly because allied health practitioners don't claim Medicare often don't claim Medicare if they're in private practice, and if they're working in a hospital and health service, they are invisible almost to the system. So the other recommendation 4 is that there should be a Chief Allied Health Officer appointed, and Dr. Anne-Marie Boxall was appointed in 2020, and one of her early goals was getting that national allied health workforce data strategy up and going. Okay, so you might be wondering quite what allied health rural generalist might be. Sometimes people think that it must be somebody who can both provide speech therapy, occupational therapy and physiotherapy. No, it just means that within each of those professions, you have the broadest possible scope of practice. So in the 2021-22 budget announcement, there was an expanded program for scholarships. There were 90 places to train, so 30 in rural and remote communities generally, 30 in Aboriginal community-controlled health organisations, and 30 allied health assistant scholarships. Allied health assistants are seen as a very important part of rural and remote allied health service provision, and they are particularly important in ensuring that we have a culturally sensitive and responsive service.
2-minute warning.
Oh, I better hurry up. Okay. So there are 9 allied health professions that offer rural generalist scope of practice, and I'll just put them up here. There we go. What are the priorities for rural allied health? Promoting rural allied health generalist pathway, developing workforce policies that align and support rural training, and building a networks of rural multidisciplinary teams. We also have a vision for rural nursing to attract and retain appropriately skilled nursing workforce, nursing generalists working to the top of licence, and we are currently developing a rural and remote nurse generalist framework to assist future rural nurse careers and opportunities, so that a nurse can identify the skills that they need to become a rural and remote generalist. So September 21, we established a steering committee, and they are developing a framework. The intent of the framework is to describe the unique context of rural and remote area nursing practice. And it's designed as a tool and guide to benefit rural registered nurses in rural and remote settings and their employers and educators. You can go and have a look at the framework, which is now open on our website, on the consultations website, and you'll have a copy of this presentation that you can look at. There we go. Any questions?
Well, thank you, Commissioner. Can I ask you a question to start with? You've been around Australia a fair bit. Examples of innovative models of care that we could learn from. Have you got a couple?
Yeah, look, one of the so just thinking, I'll go straight to the recipients of the first round of PRIM grants in East Arnhem Land. They are developing a platform so that youth can access on their mobile phones to assist them when they have mental health concerns, either for themselves or for a friend or family member. And it's designed by and for young Yolngu people. And it brings together general practitioners, psychologists, occupational therapists, and psychiatrists. So that's a sort of a virtual multidisciplinary team. And then there's another one that I really like in the northeast of Victoria, around Beechworth and Beechworth, Mansfield, Bright, where they are bringing together all of the aged care facilities in the district, working closely with the general practices and the hospitals to make the transition of care between aged care facilities, general practices and the hospital seamless. And I'm really excited about that one. Yeah, those are a couple of examples. Yeah,
oh, that's great. Questions from the floor. The time is open. I can't see everybody's face or hand, so just open your mic and ask a question if you have.
and if you haven't got questions, Paul and I might just have to keep on talking. We can talk till the cows come home.
Someone has just in a flight path from the sounds of things.
Yeah, that was me.
So did I hear? So another question, Ruth. You mentioned about the the inverse care law or the inverse health outcome law. Of the more remote you are, the worse the indicators. Is that a continuous thing right from the middle of the city out to the bush, or are there particular areas where there's dramatic changes to that, and beyond which the results are worse?
You asking that question makes me think that you know an answer to that, Paul. I know that there are certain clusters where there is much worse, where there are much worse outcomes, and they generally relate to socioeconomic status, both employment and education and indigeneity, but I couldn't be more specific than that.
Okay, so social determinants of health play a big part.
Yeah.
Any other questions from anybody else? I realise the time is short, so I think that what remains is to say a big thank you. Thank you for the work you are doing on our behalf as National Rural Health Commissioner, and thank you for explaining that so concisely to us. I'm sure there'll be people who have looked at what you're doing and going, oh, that could be interesting for my work. How do we get in touch with you?
I've got an email address, nrhc@health.gov.au. And interestingly, when I put that into my private email account, it comes up as Paul Worley. So
there you go. Whoops. Okay, so there's the way of contacting Professor Stewart. Thank you so much for inspiring us with the work and those examples of what's going on around the country. I hope that in the future people will be able to look at what's happening in Riverland, Mallee Coorong, and say, hey, there's some great examples of what's going on here as well. So thank you all for being part of this grand round, and on with your day. This will be put onto our YouTube channel, so you can point people to it if they wish to see the presentation afterwards. Thank you very much, Nakan.
Thank you. Bye.